the pulmonary function test helps to diagnose, okay? Now, in obstructive lung disease, the lungs are obstructed, the air has trouble getting out, okay? So in obstructive lung disease, I want you to think about this. The air is coming in, but it's having trouble getting out. Air is coming in, but having trouble getting out. We're going to repeat these things a lot, so that way we can help understand these diseases and get them where it's super easy when we get nervous in taking our board test, that this is super easy for us and we can do this very easily. So COPD is an example of this. Asthma is another example. We'll learn how to distinguish between the two from another portion of the pulmonary function test. Bronchiectasis, we can do this. And cystic fibrosis can have obstructive lung disease. Air gets in, but it's hard for it to get out. Restrictive lung disease is the restriction is the air going in. It's hard to get the air in. So it's restricted from filling. The patient is restricted from filling. Interstitial lung disease, pulmonary fibrosis, sarcoidosis, those are difficulty for the air to get into the patient's lungs. Chest wall pathology, kyphosis. Okay, so kyphosis is where the spine is bent forward like this. See, the spine is bent forward. You're going to see some of your older patients will have kyphosis where the spine is bent forward. Now just do this yourself. How hard is this to breathe coming in? It's pretty hard to do. You don't want to be like that, right? You don't want to have that kyphosis. Just think this is going to affect the way you're breathing. Scoliosis can do that too, curvature of the spine. So remember, kyphosis is the bend at the top of your spine. Lordosis is the bend at the bottom part of your spine. Okay, lordosis gives you the big butt, right? Lordosis, I guess that's desirable. Kyphosis is not desirable. And then we're going to talk about an intrinsic, obesity can do this too, is just think about it. If they're obese, they basically have another person sitting on their chest wall. It's harder for them to breathe in, to get that negative pressure, to get the air going in. Also too is they may have fat here in their body, but they may have increased hypertrophy of tissue inside their airway. As we talked about before, you have the greatest lungs in the world, but if you can't get the air in because the tube is occluded from hypertrophy of the tissues in the oral airway, which can occur in obesity, and it also can occur in what disease can that occur in, is we have apnea. Sleep apnea can cause this too, hypertrophy of the tissue. Neuromuscular disease such as ALS and muscular dystrophy don't have the strength because we got to get that negative pressure to get the air in. So I want you to remember too is if we say extrinsic, we want that's outside the lungs. Extrinsic is outside the lungs. Intrinsic is the lung's fault. So when we're talking about in pulmonary disease, if we say intrinsic, think about the lung problem. Extrinsic, we're thinking about outside the lungs. Now, we're going to briefly discuss PFTs. PFTs are learned through a pulmonary fellowship. We're getting you the basic information so you can able to read the report to take care of the patients in your wards, on your clinic, and in the ICU, and also be able to correspond with other providers. You're not going to be able to do a PFT and read PFTs. Remember, you have to go and get a pulmonary fellowship to do that. So part of the components are spirometry. We're going to go through the flow volume loops. Lung volumes, we're giving the volumes of the lungs during different portions of the breathing cycle. And then the DLCO, which is diffusion capacity of carbon monoxide. So if you have alteration of diffusion of carbon monoxide, something is wrong with your alveolar membrane, meaning that they give, now they're not trying to kill the people. Remember, carbon monoxide is toxic, right? They're not giving big doses over an extended period of time. They're just giving a small little dose, and they're seeing how it diffuses across the alveolar membrane, if it's faster or slower, and that helps us. Remember, we're determining what's going on with the lungs. We're doing an echo or an autopsy of the lungs while the patient is still alive, and we're not going and cutting the lungs out so we can find out what disease they have inside. So how to report a PFT? It's reported as a percentage of predicted. And what do we use to as our guidelines for this? So basically, to set up PFTs, they got people with different ages, different genders, and heights. Remember, our lung volumes are based on our heights. It's how tall we are, it's not how fat we are. As we're fat, the lungs aren't going to expand. It's the height. So what they did back in the day is they did these studies, and we figured out what the normal should be based off of height, age, and gender, okay? And from there, we used to say, are you normal or not from these group of people that we've tested? So normal is going to be between 80 to 120% of predicted from this data set that they did many years ago. And this is the factors are age, gender, and height. And what are we testing? These lung volumes. We're going to get is what? Our FEV1. This is what we breathe out like this, real fast in 1 second. Forced expiratory volume in 1 second, just like that, real fast. Then we get our forced vital capacity. This is our whole breath in and we force out. That's why we have to have a really good PFT tech, because we really want to get these patients to take a good deep breath in, and we want them to expire out so we get good numbers. Good PFT tech gives us great numbers. And then from there was we do a ratio of our force over our full force vital capacity, just forced in FEV1 in 1 second, versus our full force vital capacity, FEV1 divided by FVC. We also use, from that machine, remember they blow into that machine, we get our flow volume loop, okay? We're gonna go through some basic flow volume loops. They do test these on boards, they pop up every once in a while. We need to be able to go through these. So now the question is obstructive versus restrictive. Obstructive PFT versus restrictive, okay? So in obstructive disease, okay, I just want you to think is you're gonna have a decreased FEV1. We're gonna have that both in restrictive too. You're like, well, that doesn't make sense. Obstructive versus restrictive, okay? But our FVC in obstructive, our forced vital capacity, our full amount that we're blowing out is gonna be normal to decreased. We're gonna say basically normal, okay? For our example. And restrictive is gonna be decreased. But they're both decreased in a similar amount so that our FEV, FVC ratio is gonna be normal to increased. So you have to remember is in restrictive, I want you to think the lungs are restricted both in our FEV1 and FVC, restricted in both. I'm gonna say that again, FEV1 and FVC. So in our short bursts and our long bursts, and that ratio is gonna be normal to increased. In obstructive, you're gonna have more of a decrease in our FEV1. We're gonna have more of our decrease in FE1 over FVC, so we're gonna have a decreased ratio. So this is all we have to remember. And our number, our point of inflection is 70, okay? So in this question is that for FEV1, FVC, if it's decreased more than 70, we look at it obstructive in nature, okay? If it's a normal to increase, we look at it restrictive in nature. All right, now we're gonna go over basics in the flow loops. Now I know when learners look at these, they go, oh my gosh, this is horrible. We're gonna make this real simple, okay? We're gonna have on the x-axis is our volume. This is our x-axis. Remember we had to learn that crazy geometry stuff just so we can go through this stupid lecture, right? We went through a whole year of geometry just to do this stupid lecture. All right, so here's our x right here, and this is the volume which we breathe out. And then this is the flow is how fast, this is liters per second. So when you're in the lab, and I want you to think about this patient in the lab, and they're taking that breath. So they're gonna first, the tech is gonna say, all right, take a deep breath in. So they're gonna take a deep breath, and this is the start of the curve right here, right here. This is the inhalation. This is where you're breathing in. Look how I'm doing this beautiful drawing right here to help us out, right? And then they're gonna go, all right, breathe out, and they're gonna breathe out, right? And this right here, this is our exhalation. This is a normal curve. This is a normal curve. This is inhalation right here. We're gonna draw again, right here. This is where our tech, and then our tech's gonna say, let's breathe out, let's breathe out. And this is our inhalation, exhalation, okay? All right, so that's a normal curve. Now, we're gonna look at abnormal, and they will throw these on the boards once in a while, or you may get presented this, maybe a patient goes, here, provider, I'm coming to your office with this nice pulmonary function test that they printed out. Can you interpret this for me? And so from looking at this, you can go, oh, yes, I can. I can get you an interpretation because I paid attention. All right, so in obesity, this is an obese patient, and I want you to think everything is gonna be kind of reduced. They're gonna have what? Diaphragm displacement, because they're gonna have their belly's gonna be pushing up on their diaphragm, abdominal fat, and they're not gonna be able to do what? To take deep breaths in, right? So you're gonna have we're gonna have smaller volumes, both inhalation and exhalation. You're gonna have reduced expiratory reserve volume. So you're gonna have reduced the expiratory reserve volume because we have less volume to blow out. We're gonna have increased airway resistance, so obesity is associated with hyper-responsive and reduced airway lumen. Why? Because you get more tissue, more fat here, there's fat there. contributing to the increased work of breathing. This is an example, so let's go back to obesity real quick, okay? Overall reduce. Just think that they have an extra weight on their lungs, and it's gonna have decreased inhalation, decreased exhalation. Now, neuromuscular weakness is gonna be kind of similar. So in neuromuscular weakness, it's gonna be similar. It's probably gonna be more severe. Now, they're not gonna ask you to say, all right, I need you to identify between, is this gonna be a neuromuscular or obese? They're making it easy for you, but we're just kind of thinking about so we can understand when we get these tests presented to us. In neuromuscular weakness, okay, what can we have neuromuscular weakness from? A disease like ALS, or what about another thing? If you're given narcotics, you're gonna have neuromuscular weakness, correct? Or if you're having generalized weakness because you've been laying in your hospital bed for weeks on end. So you're gonna have reduced lung volumes, reduced flow rates. You can see here your flow is gonna be reduced here. Your flow is gonna be smaller. And you're gonna have a normal or increased FEV1 FEC ratio. So reduction, similar to obesity. Now we're gonna look right here is, this is kind of, we're doing discussion and we're gonna go towards asthma and COPD. Just remember, I wanna remember this loop again, is we're gonna have our inhalation and our exhalation. So remember, we're able to, in asthma and COPD, we're able to get the air in, but it's harder to get the air out. And we're gonna see different levels of getting the air out. Between asthma and the different stages of COPD, it's gonna be harder and harder to get the air out in our more advanced stages, okay? Now, are PFTs done in the hospital? It's pretty rare for them to be done in the hospital. Usually the PFTs, most pulmonologists are gonna want a stable state for them to get a PFT. Once in a while, you'll get a pulmonologist who has a baseline of this patient, and know this patient specifically, and they know where they are, and they want to see where they are in an acute phase. It's very rare, though, that you would get these done inpatient in the hospital. Can you imagine, is this if you're having an asthma exacerbation, to go in that booth and have somebody screaming at you? It's probably not going to go well. It's probably not going to be the best day of your life. Or if you're having a COPD exacerbation and you're fighting for air and somebody's got to wheel you down the hall to get to the PFT, and it's usually in another building anyways, and so that you can die in the hall to get this PFT. So they can get the PFT for you in the funeral home. So usually you don't do these in acute settings. So when we're looking at these diseases right now, we know they're going to get the air in, but it's going to be the trouble of getting the air out, and what degree and how they're getting the air out and how long it takes them to get the air out is going to be the important factors. So we're going to have here in asthma, here we're going to see right here, is compare this to normal. It says they're getting air in, okay? They're going, the tech is going, all right, breathe in. This is the inhalation portion. Then the exhalation is going to be longer, and it's not going to get as high. They're not going to have the same flow liters per second. All right, now let's go over to emphysema. Let's go back to asthma. See this curve right here? See how it dips in? So they're not asking you to know the intricacies of the PFT. They want you to be able to interpret the difference in the flow loops between these. See, look at this, and when some patient has asthma, it's going to be a longer, and their curve is going to curve in like this. It's going to be harder for them to breathe out. Here's another example. This is a patient with fibrosis. Look at this one. They have restriction, both kind of, they're not able to take big inhalations, see the small volumes, and once they get those small volumes, it's harder to get them out. That is fibrosis, would be an example. Everything is going to be kind of reduced in fibrosis. This shows a restrictive pattern with a normal shape. So the shape is the same as normal. Let's erase this again, and we can see what beside my beautiful drawing here is the shape is going to be normal. It just shows smaller than expected lung volumes. That is going to be in fibrosis. Over here, now this is where it becomes more difficult, and this is where we're going to discuss a fixed, let's go right here. This is a fixed obstruction, okay? Let's get our beautiful red marker on here, and we're going to see a fixed extrathoracic, outside the thoracic area. So what are areas outside the thoracic area? That's going to be the nose, the mouth, the pharynx, and the larynx. Outside the thoracic area, nose, mouth, pharynx, and larynx. Okay, I'm being annoying on this so that you help remember. So this is a fixed obstruction outside. It's going to be in the nose, mouth, pharynx, or larynx. So what can this be? An airway tumor, a goiter, or tracheal stenosis. Tracheal stenosis, or narrowing of the trachea. Now, trachea can be in the intra or extra. We're looking at this example, we're going to use extrathoracic. So, because this is a fix, you're going to have both. So they're breathing in, and they can't breathe in anymore. They can't get any more in because they have a fixed obstruction. And just when they breathe out, because it's a fixed extrathoracic obstruction, and breathing out, it's limited. So see where we have flattening right here? This flattening in the inspiration and flattening in the expiration. That's all you need to know. That's all you need to know is you can remember this. And if you get a question on boards, you can think this through very quickly. Or if someone hands you a PFT and it says, hey, provider, what is this? And you can look through it quickly and you know that there's a fixed extrathoracic obstruction. Now, this is going to be this is an extrathoracic obstruction, well, which this was before we're going, this is fixed, this is an extrathoracic obstruction. This is not a fixed one. Remember, extrathoracic, this is nose, mouth, pharynx, and larynx. And this example would be, as we talked about, the vocal cord dysfunction. So they're going to be breathing in, but they're hitting closed vocal cords, so that it's only so much volume you can breathe in, and then they're breathing out. Same thing with epiglottitis, is we have inflammation on the epiglottitis, and we're having trouble getting the air in. We're going to come into, we're going to have, boom, right here is we're going to be limited what the air can come in, and then we breathe out. Now, this is intrathoracic obstruction, okay? Intrathoracic, okay? What areas of this is part of the trachea, the bronchi, the bronchial, and the alveolar? This is intrathoracic obstruction. An example would be tracheomalacia. This is tracheomalacia. What is this, okay? So tracheomalacia is an abnormal development of the cartilage rings in the trachea. This can be present at birth, or it can be acquired, and we'll talk about how it can be acquired. They have abnormal development of the cartilage in the tracheal rings, so they're not as strong. In the trachea, remember the windpipe, the tube, it collapses or softens during breathing. Acquired factors can be such as GERD, reflux. Remember that acid, if we took that acid out of our stomach and I could put it on this desk right away, I can destroy this desk. So that just flecking up destroys that soft tissue, or that tissue inside the body, but it can also cause damage to the trachea. Chronic lung infections can do this. And maybe the patient had a tracheostomy, and that's a surgical tube, remember, that we're going to place into the trachea. Or other growths can cause to have acquired tracheomalacia. Remember, tracheomalacia is collapse of the airway. Remember, that's why our trachea, you can kind of tap on it there. It's firm. You don't want it to collapse. And if you love looking at Marvel movies, the young lady who played Yava Belova, who played as, that's going to be Black Widow's sister, just so you can get that little history in case they ask you that on one of your board questions. And Florence Pugh, the actress who played that, she has tracheomalacia. So when you come up to her and you have to fight her, just chop her in her throat, she's done, okay? That's how you survived when you get attacked by Black Widow's sister. All right, PFT interpretations. We're going to go to the PFT interpretations for obstructive disease, and we kind of went through this. The FEV will be decreased to a greater degree than the FVC. So the FEV, we're just going, our short breath out, will be decreased at a greater degree than the FVC. We'll have a below normal value, say less than 70. Less 70, so it's going to be decreased. Restrictive, the FEV and FEC1, they're all restricted. Remember we saw that flow loop where they're all decreased? It will be decreased to a greater degree. So decrease is similar degree, so the ratio is going to be greater than 70%. So it's going to be normal or increased. Once you know that, you got obstructive versus restrictive. You got this, right? Really easy. High yield PFT. These are things that kind of give you points on boards and when you have to interpret or review PFTs. It's tests to differentiate between obstructive versus restrictive lung disease. Total lung capacity, it's going to be low. Total lung capacity, remember restrictive, everything's low. Low FEV1 to FEC ratio. And obstructive, we went through this, we're beating this horse, so you get this in your brain. Diffusion capacity, remember that's how much CO2, carbon monoxide, carbon monoxide, CO, I said CO2, that's a mistake. CO, carbon monoxide, and we're going to diffuse the diffusion capacity of carbon monoxide. Remember, it's just small amounts. We're not trying to kill patients in the pulmonary lab. The patient holds their breath for 10 seconds, during which a fraction of carbon monoxide will be removed across the alveoli, across the alveoli capillary membrane via simple diffusion into the bloodstream, and it measures that amount.